you guys. All right, so I want to thank everybody for bearing through a bit of technical difficulties, but it seems like we're all in, and we want to welcome you to our first ever Meet the Author session. I'm Andrew, I'm the Education Coordinator here at Caregivers Alberta, and today we're joined by Karen, our Manager of Support Staff and just guru of all things support. And we've been working really closely with our guest author today, Kim Fraser, and I've come to learn a lot about all the many hats that she wears that I'm sure she'll kind of dive into. So again, if anybody has any questions or wants to participate in any of the things that arise throughout Karen and Kim's chat, please do use the chat and I'll bring those to the attention of the panelists. And yeah, hope everybody enjoys the session, and I'll just throw it to you, Karen.
Perfect. Thank you so much, Andrew. And Kim, yes, welcome. I'm glad that we all kind of made it onto the technology here. So, and welcome to all of you who are attending. It's great that you're here for our first session. You know what? I am going to let Kim do a quick introduction of herself, just because Andrew and I are going through, and I have a really long bio, and I think it's better if you just do a quick introduction yourself, Kim. So turn it over to
you. Hi, everybody. As my name says, I'm Kim Fraser, and I won't go into too much, but if you want to know more about me, you can find me on my website, KimberlyFraserAuthor.com, and I'm sure the links to some of that will be at the end of our session when this gets posted on the various channels that Caregivers Alberta has. But briefly, I'm a nurse by original education and health educator, health promoter, became a nursing professor. I ran a home healthcare company for 25 years here in the city with my husband as my business partner. But the last, say, I don't know, 15 years before I retired, I was heavily entrenched as a nurse researcher at the University of Alberta in our Faculty of Nursing, which is one of the top nursing schools in the world, just to put a little plug in for the U of A. And there I focused on researching. I started out with looking at knowledge use and knowledge translation in terms of how we use knowledge we have to set better policy, bringing that into case managers and looking at what kind of information they use to determine care needs with families and clients, and did a lot of research around health policy and health systems as it relates to community care, including home care, and just found I was drawn to take a deeper dive with family caregivers. So over my career, I've worked with countless family caregivers, in the hundreds really, and I've actually interviewed over 75 for various research programs. And being the author, we're here tonight going to talk a little bit about some of the content related to the Accidental Caregiver. And you'll get links if those of you didn't already get the link in your invite to get 25% off. You can do that after the program if you're interested. And I've been involved with Caregivers Alberta for many years, actually since its inception almost 30 years ago. But more so as a community colleague, collaborator, supporter, but then came onto the board in around, 2012, I suppose, or 11. And so I was on the board and in mostly on the executive role, serving as president and vice president, or past president for many years. So a real champion for the work that we do at Caregivers Alberta, and happy to be here tonight.
Hey, thank you so much, Kim. And yeah, and we're very excited and honored to have you as our first author. I can't imagine who else would be. So thank you so much. And again, for any of them, I'll hold it up in front of me so you can see it. So The Accidental Caregiver is the book that we are discussing tonight. So let's jump right into it. What is your reasoning behind why did you want to write this book?
Well, as I said, my research went into the world of family caregivers, and I had a lot of academic publications under my belt, which are just journal articles in various peer-reviewed literature, where it's mostly students and other academics around the globe who also study in this area who are seeking that kind of information. And I really felt, because I believe in using the best possible knowledge and getting knowledge into the hands of users, and I thought I need to find ways to get my work out to the general public. So I went, and when I retired early so I could spend time writing books, because you don't have time to write really what your heart desires as an academic. I really wanted to write my research findings up and write the articles that I did, but I was really compelled to write for the general public. So I realized I didn't know how to write a book, so I went back to school again and took a Master of Fine Arts in Creative Nonfiction at King's University in Halifax. And it's a low residency. You have mentors to work with. So in the end, my book represents about 9 different family caregivers, including my mom, who looked after my dad. He had MS and lived at home for 21 years. And their story is woven throughout my book. I probably have some things about that on my website. But that really was why I was compelled. I believe family caregivers need information. We're starting to see a little bit more literature in this field, but it's really important to read the stories of others, because we don't always get to sit in personal space with other caregivers to realize we're not alone. So I just really felt compelled to get some stories out there.
Okay. Thank you so much, Kim. And definitely the way that this is written, if anybody hasn't read it yet and is thinking this is academic, it is incredibly user-friendly. It's written just so exactly that any family caregiver can pick it up, can understand, and it's beautifully written that way. Really quickly, I'm just going to say, I know some people occasionally are raising hands. If you could just put comments into the chat, I'm going to talk with Kim for probably about another 40 minutes or so. If you do have questions, we can definitely put those through, and then we will open it up for the last little section as well. So, Kim, jumping into the book now, you discuss sort of having to switch approaches when you're going from, say, the intense, acute first diagnosis type of thing to figuring out, oh, I'm going to be a long-term caregiver, and this is not going to be over with in a week or a month or even a year. What are some of the main things that you would kind of look at and tell people are the differences and how to make that switch?
Mindset comes to mind, and how we approach it. Yeah, I think being an acute caregiver, meaning someone goes in and out of a period of illness, infirmity, maybe an accident causes some issues that we need to provide support and care to our loved one till they're back on their feet again. We know there's an end to it. Regardless of how intense it is, we know it's not going to last. Think about something like someone going into hospital for an operation. A relative breaks a hip and needs rehab and comes home. Depending on how old someone is and what their health status is, that can move into long-term care. But hopefully, things like broken bones that happen suddenly and quickly, we can support our loved ones to get back on their feet. Those are acute episodes. The long-term, sometimes they go into long-term, as I said, the broken hip, if it's an elderly person who's already frail, but it might be someone with a diagnosis of a catastrophic illness, cancer that goes in and out of remission, where we're providing longer term support till someone, recovers again. I'm talking what I call relentless caregiving. And that's what my mom did with my dad. My dad was diagnosed with chronic progressive MS in 1980. I was first year nursing school. My youngest sibling was 10. The other 2 were in the middle. So kind of a young growing family. and Dad was stumbling and falling, and he was fully retired at the age of about 45 after his first few years, and in a wheelchair full time from about his early 50s. So he died at 64. My mom retired early from her nursing career, but before she did retire, she was caregiving for Dad before and after work because we were all growing up moving away. I was in nursing school, started moving away. So over the first 10 years of Dad's illness, we all grew up, went to university, and, we're launching our careers. We're a very close-knit family and always were there, and a few siblings stayed home. Um, I know choices of some of my siblings to be nearby, my brother in particular, he became the support system for the family. So my mom was a relentless caregiver, day in and day out, no escape. And I think we need different coping strategies. We need different knowledge. We need a different mindset in order to be a well caregiver and looking after our own physical and mental and emotional health through that journey. And it's not that we don't want to do it and don't want to be that caregiver. And being a caregiver is not a pathology. It's not an illness in and of itself. So I worry about, we advocate a lot for support for family caregivers, which is super important, but it's not a pathological condition. It's a social condition that needs a ton of support, both getting support for the individual and supporting communities of caregivers. So I can go on and on. So
Yeah.
I'll stop there and let you tell us where we should go, Karen.
Perfect. Thank you so much for that, Kim. And yeah, that is exactly, it's like figuring out what do you need to do to get through this and not burn out. And actually that leads us beautifully into my next question, which is you have a really nice section on resilience and talking about the importance of resilience. What do you think are some of the things that that caregivers do need to be able to build up that resilience? Because it is something that everybody has within them. Sometimes we just need to work on it a little bit more.
Yeah, I mean, that's a good question. And if I were to tell caregivers, what is one of the biggest things that you could do to support yourself through caregiving is to think about your resilience. How resilient are you, and what do you need to build your resilience up? And resilience doesn't mean that you can take things thrown at you day after day after day. It means that you take the tough things, you take those crises, you deal with the crises head on. It's okay to be struggling for a little while to learn something new, to get through something, but then we bounce back and we learn how to cope. So resilience is having that ability to bounce back because you're ready for it, you're prepared for it. And things that people can do, I think we're all different, and telling somebody what they need. I think building resilience is important for all of us, but what I need to be more resilient in a specific situation might be different whether I'm a student studying and struggling with something, or whether I'm a caregiver, or whether I'm learning a new job and I'm dealing with someone nasty at that job and I don't know how to cope with it. There's those skills. And so what I need in each of those situations is different. And what I might need as a caregiver might be different than what you or someone else need. But there is some basic things that can help. Things like, thinking about your situations. One of the things that I love the most, and I think is the most helpful, is realizing you have a choice. And you might say, oh, no, I don't. My husband has MS. I don't have a choice. I have to do it. We all have a choice. You might not like what you're looking at in the mirror. You might think, oh, how could I think that I can't do this, or I don't want to do it? That's fine. We all have a sense of agency, and we have to be true to ourselves and acknowledge what we're dealing with. So we do have a choice. You just might not like the choices that are in front of you. And I have found over the years, being in difficult situations, that taking a step back, taking a deep breath and saying, yeah, I do have a choice. And even if I say, okay, I'm going to stay in this situation and I have some things that can make it a little bit better, it gives us, there's something internal. It's a mindset shift that happens when we realize, no, I'm not trapped. I can choose to do different. So I think we do have choice, and I think that does give us leverage. And then there's basic things that, take a deep breath, do things for ourselves, communicate what we need. So if I'm a caregiver, what do I need to do this? And it's okay to say no to the person you're caring for, to social commitments that people don't understand your situation and you're not quite ready to share that. Even recognizing that you have the choice to say no can give us relief. Like I feel that now, even telling you this, Karen, and saying this on the line, I think, yeah, I don't need to do all those things. And right now, this is to do with my writing and my daily work. I came across an article, and I think it works for caregiving too, or any situation. But the mantra is, don't do the things that are not the thing. So it's a little bit of a mouthful, but don't do the things that are not the thing. For me, it means stop saying yes to all these things that are taking away from a deadline that I've got looming on a writing project that's a few months away. But if I keep saying yes to things, I'm getting more and more stressed every day. What happens when I get stressed? I get resentful of lots of people's um, desire for my time and space, including my family, and that's not fair to them. So, don't do things that are not the thing. So if caregiving is the thing that you're entrenched in, and it's other things that are building and causing you stress, what can you let go of is basically what it is. But I just love that.
Yeah, no, that is great. And yeah, knowing that you do have that choice and thinking, okay, what can I do and what can I let go of? Also, just knowing that you also have the option to reach out, get that support, talk to people, ask questions, all of those kind of things. I think when we all first start caregiving, we kind of feel like we're in a bubble and we have to do it all ourselves. So definitely any of those things are wonderful.
Exactly. And then when you recognize when you are kind of taking a little bit of a resilience check and you realize there's things that you don't want to do or don't feel able to do, that's where you identify, okay, what do I need to pull in to support those areas? So you're absolutely bang on.
Um, You also had a section here on time and priorities, and I just found this so important because as a caregiver, we definitely we try to do everything and we try to do it all now, and it's like this all has to be done. What suggestions would you have for somebody who's maybe just starting out on the caregiving journey, or even somebody who is approaching burnout and needs to step back a bit? What kind of things would you tell them around the time and priorities? I mean, we've just mentioned a few of them, but timing wise and things on how to get it so that you can cope.
Yeah, I write about that in a few areas in the book, but in one particular section, I think it's called Beat the Clock. We all have limited time, but it gets back to choices, what we do with that time. Some things, some things we might need to learn to do more efficiently so that we maximize our time. That's not always easy, and it depends on what that is. So, for example, if you like home cooking and you're a cook, as I am, I spend a lot of time doing meal prep and cooking for my family because that's how I want to eat. But, this week, for example, I'm going to be an acute caregiver tomorrow. My husband's going in for surgery at the Royal Alec. We've had to do, it's just for a nose surgery so he can use his CPAP. So it's not life-threatening, but he's been very anxious about it all week, as I would be too. And I didn't tell him that. I said, you'll be fine. So my role is coach, and then running to the hospital and the doctor for these pre-op forms that you need to get filled out. So our week was really busy. And I said, go to the store and buy those salads that are pre-made. I rarely buy those because they get old really fast. But this week, We did that. I made a big pot of homemade soup so we could have that. I said, I am not cooking all week. I have so much going on. And so if you're caregiving, that's one area that you can save time. And we think about food, people always say, let me do what I can help. And we never want to ask for anything. Tell someone, well, you know what? Would you please make me lasagna or make me some homemade soup or a chili or whatever you feel like making that I can have in the freezer, and make it in small portions so I can take it out just for however many people I need to feed. You know, I think eating well is super important for our whole being. And when we're a caregiver, eating well is one of those things that gets shoved aside. So I always think about, you know, how can we save time and still eat well? You know, planning. My mom with my dad, her hands-on care for him, and she had home care 2 hours a day, 7 days a week, and we had 4 hours a day, once or twice a week for her respite. This is in Nova Scotia. And but she had to organize herself because she needed, if she could cope well and manage her day, if she got up, she had time for her shower, to have her cup of coffee by herself, read the newspaper quickly or whatever flyers she wanted to look at, and then tend to dad. So she had to get up earlier, but that gave her more time in the day, and then she would snooze with dad late afternoon when he was tired. So it's, we need to think about how we can be more efficient. But again, giving someone a recipe is not always easy. So I think it's like when we had a small child, if anybody's a mom out there, remember when you have babies, where did you find time? Well, we did things when our children were sleeping. And if we were really tired and up all night, we slept sometimes when they were sleeping. But I just think not pushing ourselves at the margin every single day is important for time management, because if we're up against the wall every day, I know how hard it is to catch up and step back. But we do have to, what can we knock off our plate so we can step back and look at what's going on and actually plan? You know, we can't plan for everything, things come up, but if we can plan for 80% of things, we have capacity for the 20% of chaos, or 60-40, whatever it is. But without that good planning and time management, and I appreciate with chronic disease and changing life circumstance, every time someone's stable, we're just getting things under control, something else happens, and then we have to relook at how we're living. But these are practical things that can frankly help us cope or not cope, or cope in a healthy way versus unhealthy.
Yeah, and listening to what you're saying there, and like for me, I have multiple care recipients, and so I always joke that, okay, you guys have to take turns. It never happens. But one of the things that you said that really kind of got me is going and getting the salads. Just knowing that you don't have to do everything perfectly for all of the other parts of your life all of the time. It's okay. Like, I know just before Christmas, we had this big conversation about, okay, well, if it's not going so well, I am not doing a big turkey dinner. I might just get a Costco lasagna.
Right.
Does it really make a difference? I mean, yes,
Right.
it's the festivity, but it's getting together with family. Like, what is the important element of things? So yeah,
and
for
it's going to
sure.
keep you whole. To me, some of these decisions are about protecting yourself. And how do you want to be? Because I don't think very many of us like to feel all tensed up in our chest and a little bit resentful and a little bit angry because we don't even have time to sit down and have a cup of tea.
Yeah.
When, you know, and that's always my cue. Like if I can't sit down and take a breather, something's got to go here, because we're just a family living life. So what can I do to fix that?
Yeah.
And yeah.
How it goes. And again, you're just leading me into these questions beautifully. The next one I wanted to talk about was really that conversations and listening, and really where that is so important. And I know that we talked about this when we were talking about the book before, was you have to tell people. You have to tell people what you're going through. You have to tell people what's going on. And so, yeah, like what would you suggest for caregivers when it comes to kind of interacting with other family members or interacting with healthcare professionals? What are some of the things that you need to kind of really look at?
Well, I always think these like a caregiver and a client dyad, like the family caregiver and the one you're looking after. Sometimes I think we need a communication coach to help people be honest. So I think for the caregiver, it's okay to say no. And I think before we say no, we almost again we need to check what is a hard no for me, and what do I really not want to do, or what do I think can change? I have a right to put demands on the person I'm helping.
Mhm.
I don't have to be there at the beck and call. And it's really tough because someone we love or like very much, or is a dear friend, is in a health crisis, or they've got a horrible diagnosis, or something's not going well, and we want to be there for them. But it doesn't mean at all costs. Nowhere does it say you will be the best family caregiver at all costs. Nowhere does it say that.
Mhm.
I think we do the best we can. And part of that is saying no. Like, for example, I remember my mom would tell my dad, no, Donnie, I can't do that right now. You're fine. Just sit there. I will be right in. But of course, if he was having a leg spasm or something like that, no, she had to go and help him and rub his leg and help him, get over that. But it's explaining to your loved one, I want to be the best caregiver I can, but I need time in the morning. Just give me time to have my coffee. Just, let me know what you need. I will be here. I will meet your needs. You don't have to ever worry about that. But, these are my needs, and I need you to respect that because you're going to make me angry, and I don't want to be angry. And
Mhm.
I know it sounds trite and easy to have these conversations. They're sometimes difficult, but then we can say to the one we're caring for, like, what's really important to you? Like, I notice you get anxious sometimes when XYZ. What can I do to help that? And so that we're talking about it, you know, because I'm sure that if you've been a caregiver, if you're even in the presence of and working with your family members, whether it's a sibling or your spouse or one of your children, we know when they're getting anxious, but their anxiety isn't because of us. Something's going on, and we have to talk about those things. So I think it's really important to ask the person we're caring for, okay, these are my buttons that I need you to be careful about because this is how I feel when you do XYZ. But what can I do so that we have a calm, peaceful existence here? And then it can be, at least it's the beginning of a negotiation. And if they say,
Mhm.
oh, nothing, I appreciate everything you do, which is quite often the case, people do, for the most part, appreciate. But then sometimes the person who's in need of care can become quite demanding. And it's
Mhm.
okay for us caregivers to point out that that's not okay.
Yeah, exactly. And looking at, yeah, what is that relationship? And then
Mhm.
the other part that kind of makes me think about it a lot is we have a lot of people who it's a siblings taking care of, say, a parent,
Mhm.
and one sibling is doing the majority of the work, and the other siblings are maybe participating or not participating or complaining about how one person is doing it. And those types of communications as well, with
Mhm.
just making sure you're letting people know this
Mhm.
is what's happening. And
Yeah.
um, like I know when for me it was there's times that I was just like, geez, can't my husband see or can't my brother see what I'm
Mhm.
doing and that
Mhm.
I need their help? And it's like, well, but I've never asked for it. So it's like
Right.
knowing that you have to actually verbalize that. You have to
Mhm.
actually say, you know what, I could
Yes.
really use your help.
Very important. And then working with health professionals or your physician as well, you might think, oh, I'd like to try this kind of medicine or something, or I would like to be sent for physio, or you might have ideas, or you might have questions about this a specific disease, or the kind of care that you can receive if it's home care. Write things down, go into conversations prepared. And you can do this with your family members as well, because when we're talking with our family members, it's easy to get heated if conversations don't go our way. Then we forget our train of thought, we forget what we wanted to cover. I find if I have some points written down and I can say, okay, we're getting off track, let's bring it back. And it can be really helpful, but especially going in with health professionals who might either be busy or we perceive them to be busy. We don't want to take up their time. We tell them, I have a list of questions that I need to go through before I leave here today. And that helps keep on track. So yeah, and I talk about that in the book as well. And in the care book, which is a companion, that you'll also have a link to get some 25% off. It's like a family care plan where it cues you to actually write things down, the kind of information you might want to keep track of, suggestions on how to keep track of it. So, and once you get the book, there's a note in there to go to my website where you can actually download extra pages or use a binder format if after you've had this to take out some of the templates. So.
And actually, I'm just, again, thinking back to some of our conversations when we were setting this up. And one of the things we're talking about, taking your list in for healthcare providers and asking questions. And sometimes you do have a healthcare provider who's just, okay, it's a specialist, they're in a hurry. Call back in and talk to the nurse. The importance of being able to have a relationship with the nurse that's there, because even if the specialist isn't going to give you the time and things, get the nurse to explain it to you. Say, okay, break this down how I can understand it. And I that was one of the things that you said to me. And I really remember that. And just like, yeah, get to know the nurse. Yeah.
Absolutely. Yeah, no, build a relationship with your healthcare team. And if they're not right for you, try and find someone that you relate to.
Yeah, for sure. So Kim, going through this, most of the book you wrote kind of as a secondary caregiver and researcher. And then at the end, your life kind of changed and you became a primary caregiver. How do you think that kind of affected your view of these things that that you've been writing about and hearing about? What kind
Very
of
good
changed
question.
there?
Yes, so the question that Karen is bringing up, there's an afterword in the book that talks about my own family caregiving situation. So what happened in 2019 as this book is getting ready to go to print, I was working with my publisher and agent, and my husband was diagnosed with aggressive prostate cancer. And his dad had it. He'd always been checked. We knew we'd end up dealing with this at some point, but he was in his very early 60s, and it was just a shock that this was aggressive. He was going to need surgery. Yeah, it was like, a punch in the guts. It was a cancer diagnosis, but to hear the word aggressive was really scary. And so I took on the role of kind of that information. And I think that's what we do when there's a diagnosis in our family or where things are shifting. We take on certain roles. And so mine, obviously, because I was a nurse and a researcher and just naturally extremely curious. And I talk about this. I went to the library and I came home with a stack of books, like huge, and started reading. And I asked, I'm very aware that I'm a nurse. And when I go to medical appointments with my husband or my son, I find it very hard to not jump in and be the one leading the conversation. But I think it's very important that the client does that. So I sit back. And then when it's my turn, I say, okay. So I waited patiently while things were explained to us. And I said to the urologist, I said, please tell me where to go. Tell me what websites to go to. And he knew I was a nurse researcher. And I said, I'm going into the academic literature. And he was very good to say, no, Kim, don't even do that, because there's so much, not misinformation, but there's so much of any disease and any individual's diagnosis. A lot of our clinical decisions are about your specific circumstance. So I knew that, but having him tell me that was great. And I had the ability to take the lab work and study it piece by piece. And I was directed to some very good patient websites. So I'm just Joe Blow, wife, Kim, studying what does this mean? What do all these markers mean? And there is some excellent websites out there for all kinds of things. And I knew that, but to be on the patient side of things was very different. And so I knew my husband said, no, you look at everything, you read everything, you tell me what I need to know. That's where his head was. And so I did that, and we needed surgery. But I talk about, and I think anybody going into this caregiving situation, whatever the diagnosis is, I kept thinking in my head, oh my God, I'm living my book. I didn't really want to. Yes, I was the supporter of my mom. I was up close and center with many personal caregiving situations, but it never really happened to me. So I have a chapter in my book called Change, Loss, and Grief. Because anytime we're a family caregiver, we're only a family caregiver because somebody has something horrible going on with their health, whether it's mental, physical, whatever. Somebody has got some sort of crises that requires them to need support from a friend or a family member, hence the family caregiver. And I just remember thinking, oh, I did not want to learn this stuff this way. And but I also thought, okay, this is putting it to the test. Like, this is really testing me. Is everything I said in my book true? Do I believe that now as a family caregiver? And thankfully, the answer was yes. But I did feel that I had to write an afterword that, wow, I'm like all of you now. I am right in the middle of this. And so I talk about the challenges that I had, what I found most difficult. I talked about conversations with my husband. And even though it was, a catastrophic cancer diagnosis, aggressive, with a very, very high rate of recurrence in spite of the surgery, he's 5 years post-op now this past December, and he has a clean bill of health, and they consider you completely cured with prostate cancer after that. But I'm always on the watch. So I told our doctor, well, I still want these PSA tests to do. So that gets at my negotiation with the doctor. And he said, well, we don't really need to do it only once a year. I said, no, I want to do it every 6 months for the next little while. I just need that. So he said, okay. I mean, the PSA test is really cheap. So, but I said, no, I just really need that because I knew how aggressive it was. And I mean, it changes everything. My husband had to get used to using incontinence supplies, and while he heals, he has to go to physio to keep retraining, and the bladder retraining is ongoing. I mean, it's a minor, it's a significant everyday change in your life, but it's really minor. He's healthy. I have him here. That's all. I'm very grateful. But your whole life changes. And yeah, and I just remember working through this. I educated and coached a lot of patients on clinical decisions. So how do you choose what treatment? Then the best man in our wedding, we call him to tell him, and then he's got prostate cancer. So he has another kind of treatment. He goes for radiation that was effective for him, but I learned way more about prostate disease than I thought I would ever have to. And again, everybody's situation is different. So if there's any nurses or health professionals in the crowd, everybody goes to you and asks you. So, and then another good friend of ours, her husband was diagnosed. He had his PSA checked every 6 months as well for his job. He was a pilot. He was diagnosed after my husband with aggressive. His Gleason is the scoring system they use in prostate. His was a little bit worse. My husband was a 7 out of 10. Our friend's was a 9. And so I'm trying, giving my friend hope, and we're talking about the different options for care. Her husband was beyond being able to have surgery. He had to choose other options because there's certain reasons why you can have surgery and not. And he died 2 years later after his diagnosis. So just about a year and a half ago. So, I think anytime we're faced with a catastrophic diagnosis, it sends us all down the things that I talked about right in here. And so even though I would still say I was in one of those acute caregiving situations, my husband kind of got better, but the emotional toll of caregiving was still there. I was a support. I went to every appointment and, you know, and we do that even like tomorrow. I'll sit at the Alec until the Royal Alec, for those of you that aren't in Edmonton, it's one of our big hospitals. So I'll sit there till he's done, take him home, you know, be helping him with his meds, even though he's really independent. But I'll be telling him, no, sit down. You can't be up running around yet. You're gonna have to heal. And so you take over just certain decision-making things. And it's an anxiety, you know, provoking couple of days. You know, is he going to bleed? How's he going to breathe through the night? Is it going to be okay? And so regardless of what the situation is, we still go into all of those kind of emotional, psychological pitfalls that we can fall into. And okay, I got this. We're good. I know what we're going to have for supper. I know when my son's going to be home. Someone will be home with the dog, you know, managing all these little pieces.
Yeah. And I mean, just you talking about that and just everybody listening, it's like, okay, you're a nurse and it's still this anxiety and everything. Like for me, I mean, I'm a therapist and I ended up with a daughter with mental health issues.
Yeah.
And what I was saying and how we were reacting to that was so different than anything I would have said to a client. But you still go through it all. It doesn't matter how much you know when it's
That's
a family
right.
member. It is so different.
That's right. Yes. It is. You become, I mean, I think we have a little bit of an advantage in that we understand the system, but we're being called upon to use every skill in our toolbox. And you know, and I would have to, and then I was really sensitive. Like I would tell, you know, physicians that we're dealing with, hey, just because I'm a nurse doesn't mean I know anything about this. I know nothing about this. So, and then even if it is your field, new evidence comes out for things all the time. So we're always looking at that. And then we were offered home care post prostate surgery. I'm like, no, we don't need home care. Why would they? I don't need to waste resources, someone coming to us. And my husband was like, no, I really think they should come. I want them to come. And because you come home with a catheter, he might have needed irrigation if he had a blockage. And I'm like, yeah, okay, well, if that would make you more comfortable. I mean, I don't know the last time I did catheter irrigation. So I'm like, yeah, my husband's right. What if we get into trouble? He said, just let them come. And so they came and it was really reassuring. I had a phone number I could call. I knew what to do. They left us supplies in case we needed something. And I knew what to do in case. Well, if I had said no to all of that and then we got into trouble, that would have been really naive of me. So take everything you're offered, you know, listen and learn. And so that was learning.
Yeah, for sure. And not thinking that it's like if you need the help, if you're not sure, again, it goes back to the communications. Ask for those things. And if it's one of those situations where it's like, okay, I think I can do it on my own, it's okay to have somebody else come in and help. It's like it's an opportunity to learn, if nothing else. So yeah.
Yeah, and I
Andrew,
think Shelley, I see just a question in the chat about Shelley mentions that it's caregiving is not always a medical model. Absolutely, absolutely, absolutely. It is not. In my business, we looked after a lot of children with, you know, multiple and severe anomalies and helped them into adulthood with the local home care program. And you're absolutely right. And I end up going into these examples because that was my lived experience, but I fully support what you're saying. And it gets a little bit to, I don't want to pathologize family caregiving. The people we look after might have a pathology or they might not, but caregiving in and of itself is not. But it's sometimes hard to get away from it because it does often end up entrenched in some kind of system, but not always medical. It might be social or otherwise. So really, really important.
Yes,
And
for
I
sure.
and I do talk about that in my book as well. There's a whole cadre of families living with young people, with multiple situations. So
Yeah, exactly. You know what, Andrew, if you're there, I didn't get a chance to read all of the other questions in the chat. Is there anything else there that,
me neither. I just caught that one.
yeah. Oh, if
And
you're,
I don't know if you, while
Yeah.
you're looking at some questions, if you wanted me just to read a snippet.
sure.
Sure, yeah, go ahead.
And you can have a look at some of the questions and perhaps answer a few. So I'll just read a small section on resilience. So, because we talked about it. Resilience is the ability to bounce back after being knocked down due to a setback or misfortune. It's a quality that helps us adapt to change and challenge in healthy ways, sometimes making us stronger than we were before. And resilience is such a valuable tool. And when I found this, I just had to put it in my book. But it is such a valuable tool that the U.S. Army tested a resilience education program on more than 1 million of its people with an investment of $145 million with tremendous success in supporting their soldiers and commanders to be able to better deal with situations. So if the U.S. Army thinks they ought to spend $150 million supporting resilience education, what does it tell us about the value of resilience and how sometimes these skills that might get blown off as a soft skill are actually very important and can make the difference between coping and not? So I've interviewed and observed over hundreds of caregivers over the years who told me what they did to manage their long days, how they viewed their situations, and the myriad of ways they made themselves feel better while under prolonged stress. Each person I spoke with did demonstrate tremendous resilience, but not once did anyone ever use the word or recognize resilient behavior when I called their attention to it. So I took a closer look at the language they use when talking about their situations. I heard things like, I saw it as a positive experience. I had hope. Hope builds resilience. I knew it wouldn't always be like this, so they saw the end of the tunnel. It wasn't easy, but I'm stronger now. So they looked at the positives in their unique situations. So it turns out that these caregivers were talking about resilience, whether they knew it or not. Resilient people demonstrate characteristics such as a positive attitude, hope for the future, and a belief that they can bear obstacles, if not overcome them. Resilience allows us to flourish in the face of adversity, or at the very least, to endure. Resilient caregivers see their outlook as hopeful in spite of the adversity. Resilience helps them continue day after day and manifests in a myriad of ways. Not surprising, it is one of the most important concepts in family caregiving. And it can mean the difference between coping or not, between acknowledging the small victories or feeling like a failure. Some caregivers may have more resilience than others, and nevertheless, it is a skill or a set of skills that can be learned, which I think is the positive. So, yeah, and lots of people talked about it in different ways.
Yeah. And just going through the chat, Kim, and I think, one of the things that you and Karen were touching on was, the topic of boundaries. And it is something that I for sure know is on a lot of people's radars, like from almost every sector, almost every kind of stakeholder position that, works with caregivers or offering, programs or services towards caregivers. And then, one of the points mentioned in the chat was, having, the weight of those expectations that are on you that aren't solely just based on care. So I feel like there's a correlation between boundaries and, those expectations that we feel are always kind of thrust upon us. I don't know if you had anything to expand on that.
On the notion of boundaries.
Yes. Yeah.
Well, I think we all have our limits and we all know what's okay. And I think it changes. It can change. It's not always the same. But there are those things that are a hard stop that I can't do or don't want to do. But then there are those things that are okay. If I'm coping well, I'm willing to go a little bit farther. So I think some of these things, a lot of the things that I talk about are not absolutes. There's a big, it depends, from situation, and even within a situation from day to day.
Yeah, for sure. And I'm thinking Andrew and I were even talking about that earlier today. It's just like, yeah, how your ability to cope depending on what else is going on, or how long this particular stress or what you're coping with, or when was the last time you did get to sit down and have a cup of tea and just breathe. It really does affect how you can handle things. And again, where is that boundary? Like, okay, today I just can't push any further versus, yeah, I think I can do this today.
Yeah. And I read, and I think it depends on your relationship with the individual. I forget. I mean, I hear this often, in some way, shape, or form. If it's a son, he does not want to look after his mother's incontinence issues and, bathing, or a daughter might not for her father, those kinds of things. But so there's certain things that we all might have that we might not want to do. But again, it depends on the situation. Like I can think of times, because my dad had a bowel routine. He was incontinent, of bowels and bladder, had a catheter for years. And my mom would be, bathing and cleaning up. Dad had, our family doctor used to say my dad only lived so long because of his good nutrition and love that he got. He was so well cared for, probably at the expense of my mother's health, because that's what she did. But if I was home and dad had an accident, or it was his bowel routine, which involved suppositories and then helping him go to the bathroom, and I guess I'm a nurse, so I talk freely about these things. So so us kids would be down there helping mom, or or in the early days before dad even had the catheter, if he had an accident, well, if we were home and mom was working, we had to help him. And I mean, our family's kind of pretty open, but it still wasn't a natural thing to be helping your dad with his bowel routine, or his catheter, if his catheter get clogged, or those kinds of things. And so, yes, mostly that would be a boundary. I don't want to do my dad's bowel routine. But if nobody else is home, or if my mom goes away for 2 weeks and I go to the family home to be the respite worker for my mom for 2 weeks, well, I pretty much have to do those things. And so, but then for some other families, it might be, no, that's when we're going to get home care to come in for 4 hours that morning so they can do it. So there's those kinds of boundaries as well. And then there's the boundaries where you're not going to speak to me like that, depending on the intensity of the caregiver situation, how we accept people talking to us, or if you're a family that has external support and help and caregivers coming in, there's boundaries there. So I think it's good to talk about our limits and our boundaries and acknowledge them, because they're not bad. And if we don't address some of these very significant things in our life, things just build.
Well, for sure. And there's a couple of comments here about boundaries, and yeah, the number of people that I talk to, and it's like, well, that's a boundary. And I'm like, okay, have you let the other person know that that is your boundary? And also, what are you going to do if that boundary gets crossed? Like, you have to put the parameters around it as well, and sort of say, okay, this is what I'm not willing to do, instead of just getting mad that you had to do something. Let people know ahead of time, this is what I'm willing to do, this is what I'm not, or this is what I'm willing to be treated like, and this is what I'm not.
Right.
Be prepared to
I
walk
see
away.
a comment from Shannon about caregivers not knowing resources out there, maybe not knowing where to start or look. And I don't think Shannon might be talking only about the boundary thing, but we can even look up support now that we have the internet before us. In many cases, we can look up, how do I have a difficult conversation? So we can look up those kinds of things. But thinking about other resources, you're absolutely right, Shannon. And I do talk about that in my book. I've got a whole chapter on different kinds of resources and how to access them. And I think, and it's always, even when I was in home care, helping people find what they need. Home care is the world's greatest secret, but so is everything else related to home care. Where can you access equipment and supplies? Knowing what's available in your province for aids to daily living, for example, different programs. There is just so much information that caregivers need to know, and it's so hard to give it to people all at once because it's overwhelming and you might not need it then. So even getting at this little care book that I put together, I talk about a section for kind of supplies and resources, but I advise people if something comes to mind that you hear about or you might not need now, figure out a way to catalog it, like have a personal resource file from A to Z in a recipe box, something simple, some way, oh, that's where I heard about that. Because something that you might hear about just simply because you're in a caregiving mode, or maybe you have aging parents or a sibling with some kind of diagnosis, you never know what you'll need down the road. So having your own resource file. But in my book, what I did was told people, like I have a section on looking for resources. So rather than saying, look for X organization in your community, search terms like this, social services, where to get financial support, is there equipment or aids to daily living, because that's a bizarre term that we use that, unless you're in the milieu of caregiving, you might not appreciate what that means. But there's just so much information needed, both kind of disease specific information, kind of mental health information for the caregiver to find tools and resources to support yourself. Then you might need skills to learn how to do certain things to provide care. So it is endless, for sure.
And
So thanks for mentioning that.
yeah, and for anybody, particularly if you're in Alberta, we're just a phone call away.
That's what I was
So
going to
it's
say.
one of those
Absolutely.
things
We're blessed.
that-
And
yeah.
BC has an organization, Nova Scotia, Ontario. Just ask people. Hunt, you just need to be such a sleuth when you're a family caregiver. And my mom being a nurse in the early days, I remember she didn't even know she could get home care. She thought, well, why would I need that? And I'm like, Mom, Dad needs home care. You're at work, you're worried, you're calling him all the time. There is home care. We need to get that. And it was like just a light bulb went off, and never really thought that, oh my gosh, we should be accessing these. And sometimes we think the professionals, whether it's a social service person or healthcare, that they should know these things. Well, again, it gets back to what Karen said earlier. Unless we say it, people often don't think. Unfortunately, and when I would talk to physicians and things, I mean, it's taken us years to get nurses and doctors to think about the family caregiver and ask them in a meaningful way how they're doing. What do they need? Is there anything you could use? And we still don't do a very good job of that. And so that's why we need to be assertive and put it out there, what we need. I remember there's a woman I talk about in my book. I just really loved talking with her, and she was a pharmacist by trade, and her husband had cancer, and it was a pretty intense caregiving situation for a couple of years, and they had home care. And she told me, she said it was just so insulting. The case manager, she was great with my husband. She would talk to him, some were better than others, but inevitably they would leave, their hand would be on the doorknob, they would turn around and say, so I hope you're taking care of yourself, Dorothy. You're doing okay, right? And she said, what am I supposed to say with they've got their foot halfway out the door? I'm ready to burst into tears. I don't know how I'm even going to get through the night, let alone the week. And they're walking out the door. How do you begin to unload on someone like that? And she said they were lovely. It wasn't intentional, but I felt like they didn't have time for me. And then my heart just broke. And I'm like, yeah.
Sorry, I'm just reading some of the notes here too. I'm not ignoring.
Yeah,
But
I'm just
yeah,
saying
for
what
sure.
Amber had said, that sometimes caregivers are thought of as a nuisance or extra work.
Yeah.
And, I like to think that attitude is changing, but you're right. In a lot of situations, Amber, yeah, the caregiver
Yeah.
is not thought of, or the
Mhm.
one that's asking too many questions. And I'm sorry, we're the ones that are providing. What is the statistic this week? Is it $67 billion that caregivers are putting into the Canadian economy?
Yes, yeah, yeah.
Um, you
And
know,
yeah,
uh,
yeah, the system
yeah,
would collapse without family
absolutely.
caregivers. Yeah, it's
Yeah.
just no way it could continue. So.
Yeah, and I think and information is power. I talk about information management in my book, and knowledge and getting the resources. Information is power. I don't know what it's like right now in for different home care programs, but for years we didn't want to tell families all the menu of things that home care provides, and there was two sides to the equation. Many of us felt, no, families don't want us there. No, they want to be alone, living their best life, regardless of their circumstance, without a cadre of people coming in. So if we tell people what they want, they might help us identify what will work with them and what they don't need. And I still think we're not there yet. We treat clients and families as if they just want. And no, we really don't. Most of us do not want the intrusion of all of this in our homes.
Yeah. Now I know
Mhm.
we're kind of getting to the end of our time here, but and we said we weren't going to kind of get into respite and things like that. But that's one of the things like you're talking about is maybe somebody doesn't want somebody there permanently, but being able to have that break, being able to have that time where you can maybe get away for a day or even a few hours, a couple times a week or something is so important as well. And yeah, letting people have that option.
Right. And it might not even be respite from the system. Like, I think it's so important to identify the people in your life that could come and
Mhm.
be with your loved one and give you a break while you could do other things, or some people on the phone might not be a primary caregiver, but they might be supporting family caregivers. And so, I talk about how one of the clients in my book, one of the people I interviewed said, I just loved it when my friend Mary said, I'm coming over, I'm bringing coffee and muffins. When do you want me to come?
Mhm.
So she said, I love that. I wanted to visit. And she was asking me what a good time was. That is respite. Another
Mhm.
lady said, having my tea with my dog on my lap without my husband needing me is respite, which is gets at communication a little bit. We say, okay, Joe, yeah, I'm going to sit down. You're going to be fine for an hour. You're safe. Call me if it's an emergency, but just give me an hour to sit here and look at the ceiling.
Mhm.
That's respite for some people. Having a bubble bath, just actually being able to sit in a nice warm tub,
Mhm.
or going out in the yard. I'm going, and now with cell phones, I think, if as long as we can teach the person to use the phone, I'm going to be out in the backyard. I just want to go out and sit in my garden, or I want to go out and do some weeding. So
Mhm.
respite absolutely means different things to different people, and we can't presume to know. I mean, yeah, we're getting out of time at respite in
Yeah.
our house when two siblings lived away, so we often tried to get our holidays back to Nova Scotia together,
Mhm.
and still do. And honestly, dad's respite, it was 2 days. It was Tuesday and Friday from 8 till noon, so we all had to be showered and up and out of the house. So the caregiver came, that was mom's time to do errands. So we would be going to do errands and be out of the house for 4 hours. And so respite sometimes didn't feel like
Mhm.
respite. And of course, we didn't want to cancel the service because that messes up mom and dad's routine. We're all capable to be there. And of course, mom got additional respite while we were all home. But yeah, respite means different things to different
Yeah,
people.
for sure, for sure.
Mhm.
Well, as I said, I know we are a little bit over time here. So Kim, I just want to thank you so much for coming in, for talking to us. I'm sure that we could probably go on for another couple of hours with different things. And Andrew, I think at the beginning you put the website, but would you mind dropping that in?
Sure.
And
Yep. And we'll for sure be getting the website links, any resources Kim wants to share, and upcoming invites to our next Meet the Author sessions. We'll be emailing those out hopefully early next week. So everybody should be on the lookout for those. But yes, I can definitely drop.
And if anybody has any questions after, I mean, you can reach out to Caregivers Alberta with them for help and support if anything was sparked. And if they need to bring me in, they can certainly do that. But I'm all over. I'm not really all over the web, but I'm on social media and I have my website. But the Current, I just wanted to put this out there. The Current is doing a program on caregiving, on different aspects. I think they're mostly focusing on older people, but I'm going to be featured on the show. There's about a segment of 4 series, and I'm going to be on one of the programs. So The Current is a national radio show in Canada, probably one of the most listened to programs that CBC Radio does. Anna Maria Tremonti used to do it. Now it's Matt Galloway. So I'm working with one of the producers, and they've been in contact with some of my other friends and family and acquaintances that I know who are caregiving, but they're looking for a caregiver and a client. So the caregiver client dyad, the caregiver loved one, whoever you look after, they're hoping that they can bring someone onto the show and just talk to both parties about living the life, being cared for, and caregiving. So if that is something that you're willing to do, please let Caregivers Alberta know, or myself. You can find me on, I think I've got an email or something on my webpage. So I'm not as ill-informed with tech as I sound, but if that's something you'd be interested in, it'll happen later on this spring, and would love to hear from you.
Great. Yes, I'm sure that we will have some people taking you up on that. So once again, thank you, Kim. Thank you, Andrew, for helping out, and thank you all for coming.
Thank
Really
you for
appreciate this.
having me.
Yeah.
And thank you all for supporting my book and for all that you do caregiving. So a really important role.